here. She's a pediatric endocrinologist and luckily going to speak about some of the most asked questions in the pediatric office regarding children, puberty, and growth. Hi, Dr. Forghani. Thank you for being here.
Hi, so glad to be here with you.
I'm going to give a brief background about you, and then we'll jump right into what some of normal stages of puberty are. So first, for those who do not know, Dr. Nikta Forghani is a board certified, she's certified both in pediatrics and pediatric endocrinology. She has been at Chalk Children's Hospital since 2009, and now she's the medical director of the Chalk Pediatric Diabetes Program at the Marion Dick Allen Diabetes Center in Newport Beach. Dr. Forghani received her medical degree from the University of California at Davis and completed her residency at Children's Hospital and Research Center in Oakland, California, and there she was also chief resident. She completed her fellowship training in pediatric endocrinology at the Lucile Packard Children's Hospital at Stanford University. Yay. She has special interest in type 1 and type 2 diabetes, Turner syndrome, transgender youth, puberty disorders, and interestingly, telehealth medicine. Given the pandemic, that's a great topic. So while I did want her to speak on pretty much everything in her specialties, we're going to focus on puberty. So why don't we jump in and start with what parents can expect as normal puberty?
So yeah, hopefully I can give people some insight on kind of what norms are, what averages are, and what we consider pathology or kind of outside the norm. So I think this is a topic that we talk about, or I'm asked about all the time. I think there is a conception that puberty is happening earlier today as opposed to, let's say, when we were growing up, or if you give it a timeline, like maybe over the last 30 to 40 years. And the answer to the question is, it's true that the onset of puberty is slightly earlier today than it was 30 years ago, but it's not as different than you would maybe expect. Mm-hmm. So about a decade ago, so not too long ago, there was a kind of population-based study looking at both boys and girls and onset of puberty in multiple different locations in the country. So not just urban areas, but rural areas, so many different areas of the country. And the bottom line is, average onset for girls was around 9 3/4. And just to give you some perspective on that, maybe a similar data set was collected like over the last 20 to 30 years ago. And they reported more like 10 to 10 1/4. So again, yes, it's slightly earlier today, but really not that significantly earlier on the matter of 3 or 4 months or 6 months. And when I just define pubertal onset for girls, I'm specifically talking about breast development. Okay. And then they followed it up to look at when was the onset of their period, or what we call in medicine menarche. And it's not changed much over the last 30 years. Around 12 to 12 1/4 is still the average age of onset of the period for girls. This most recent study that they did, they really looked at kind of correlative findings of what was associated with earlier puberty or onset of puberty. And the two main things that they identified was, one, there is an ethnic distribution. So the African American girls had an onset of puberty that was significantly younger than the kind of average, on a matter of a year to a year and a half earlier. The Latina girls were also slightly earlier. And then the only other thing that they found correlative was weight. So the girls that were heavier had appeared to have a much earlier onset of puberty than the girls that were kind of a more regular weight, or more average weight. And so that's kind of what we consider the relative norm for girls.
Can you answer, since we're right here, the study showing that heavier leads to earlier onset, is there any explanation that they've been able to prove or at least understand with why that is?
There is some thought that one of the hormones that the fat cells of the body make, a hormone that's called leptin, can induce a cascade of events that leads to the body going into an earlier onset of puberty. I can kind of say that in the most basic way. So kind of the leptin levels can induce, again, a cascade of events that causes the brain to turn on. Puberty is a process the brain is what triggers puberty to happen, that there is some association with that. There is also some thought that when you're doing physical exams on children, you may be misinterpreting fatty tissue for real breast tissue. And so one of the things that they tried to do in this study was it was not just visual examination that they needed to do an actual palpation exam. So I often tell families when they're coming in for puberty issues that, I'm sorry, I have to invade the privacy of your child, but it's relevant. You cannot just look, you cannot just take a quick peek. You really do need to palpate tissue, and that's for girls and for boys. And so it's the one thing I tell, I hopefully I'm educating the children and the families that, it's only okay that your parent is here, but I'm really going to have to invade your privacy, because just visual inspection isn't necessarily enough. But to your point, there are some theories as to why weight is leading to a possible earlier onset of puberty, although not necessarily an earlier onset of the period.
Okay, so period does not necessarily present earlier. Is that just with the obesity or with all of the ethnicities? You said Latinos.
All of the ethnicity. So when they're doing population-based studies, again, maybe a quarter of a year earlier than it was 30 years ago, but not in the way that I would say. I think the perception is like, girls are presenting earlier and earlier and earlier. That's not necessarily true when you're looking at large population-based studies.
So that bodes very well for a question that I told you in the beginning, that we might actually talk about how it affects bone growth and final end height. So it wouldn't necessarily affect, just because they're starting puberty early doesn't mean that they're going to be shorter.
Not necessarily. I mean, again, we don't consider anything, any type of pubertal development for girls starting after the age of 8 to be pathological. We consider that to be a variation on normal.
Okay.
So again, just as there are on-time bloomers, it becomes statistical, right? It's like a bell curve.
And I guess I should qualify this conversation for...
And there's late bloomer.
Oh, I'm sorry, I interrupted you. Say that again.
So the pubertal onset, it's like a bell curve, right? So there are the average bloomers, the majority again are kind of as I described, the early bloomers that are starting after the age of 8, maybe even slightly prior to the age of 8, really could be considered normal at this point. And then the later bloomers that, again, for the girls, we're talking about girls that maybe haven't even started breast development by age 12 or 13, right? So those are late bloomers. And again, these are all variations on normal. There's no necessarily any pathology there. And your question of does it have an impact on the height? More often than not, no. Girls that are early bloomers are often taller than they would be in the context of their family. They have a relatively aggressive growth spurt during puberty, and they ultimately land where they're supposed to be for their family at the end of the day, right? The late bloomers are on the opposite end of the spectrum. Frequently, they're smaller than you would expect for their family. They have a less aggressive growth spurt, but they grow for a much longer period of time. Your length of time for growth is completely dependent on your timing of puberty. So for girls, generally, they will continue to grow for another 1.5 years after they get their period. So if you don't get your period until you're 14 or 15, you'll keep growing until you're 17 years old. And so do you see that even though you may be smaller when you're a younger child, you will eventually catch up because you're going to grow for such a longer period of time in comparison to your peers.
Great.
Whereas the average bloomer girl will stop their growth around 14 years of age. Because again, the average age of getting your period is around 12 and a half. Grow for another year and a half. Generally, the girls are done by the time they're 14. So I frequently hear families tell me, oh, my pediatrician did this thing when my child was 2 and they doubled the height. And they said, if you double the height at age 2, that's the height of your child. And I said, that works sometimes, or maybe even like 50% of the time. The problem is if your child has any aberrancy in the timing of puberty. Because if your child is a late bloomer, that's going to way underestimate your child's height. And if your child is an early bloomer, that's going to way overestimate your child's height. Because again, that child body, these like normal early bloomers, their bodies are predestined to go into puberty at a particular time. So their bodies are taller in the short run. And then again, at 3, they look like, they're going to these girls are going to end up being like 5'6", 5'7", but we would never have expected them to be that tall in the context of their family. And then they stop earlier than everybody else.
Do you want to explain a little bit, or I can, about why that happens, how bone development is influenced by the hormones?
So, yeah, I mean, really almost every hormone that you can think of, right? The ones that are, well known: thyroid, growth hormone, estrogen. We haven't really talked about the boys, but the just a side note for the boys, kind of average onset of puberty around 11 to 12 for boys. Puberty takes around 5 years for boys to go through. Generally, they stop growing around 16. We don't consider anything to be early unless it is under age 9. So the timing for boys is a little bit later than the girls. And again, we don't really consider puberty late until closer to more like 13 to 14 years of age for boys. So anyways, the timing is a little bit different. But so for as we call the sex hormones, so estrogen and testosterone, super important for growth and bone development, although it is estrogen that ultimately is the trigger for the pubertal growth spurt. So the acceleration of growth that happens during puberty, and also ultimately responsible for the fusion of the growth plates. And that's true for both boys and girls. So anyways, all of those hormones that I talked about, cortisol also, again, there's like thousands, some known, some unknown, that a confluence of events that causes kids to grow. Normal growth during childhood is very specific for humans, that most children grow about 1 inch per every 6 months throughout their entire childhood. So that all that confluence of hormones leads to very characteristic growth. So if you're looking at a child's growth chart and they're following a percentage line, you already know that they're growing about 1 inch every 6 months or 2 inches a year, from somewhere around 2 to 3 years of age to the onset of puberty. If your child is growing in that manner, likely all the hormones that are supposed to be doing what they're supposed to be doing are working. I often tell families, I care less about where your child is on the growth chart and more about how your child is actually growing. That gives most answers if there's any pathology or anything wrong. It really, I tell families, especially those that when they are referred to us for questions about growth, that when I get a complete growth chart, meaning a child that has been visiting their pediatrician every year and is getting measured, that is actually the most important piece of information other than labs and bone age and all of the rest of that. So it's a real, I'm a real advocate, because I think a lot of people think, oh, my child's healthy, they got all their shots, they don't need to go see the doctor anymore. It is not true. The growth chart tells so many secrets about your child's health. And when I see a child that hasn't been seen for many years and then they come in and they're at a particular, it's like, I can't even interpret that one point. I need to look at trajectory. That's the most important point. That's the most important part of an evaluation for growth and for puberty.
And I think this is a time to tell parents that they need to advocate for looking at the growth chart with their pediatrician and asking questions about it, because sometimes it stays tucked away in the back of a paper chart, or some measurements went in wrong and the computer has a weird chart. So do review that with your pediatrician. Everyone's usually pretty good about it because we do know it's very key. Do you want to speak do the hormones have any puberty hormones, do they have any play on delayed growth? Because we'll talk about delayed growth, constitutional delayed growth, and what that is. Maybe describe what that is to people, because it's so common, and maybe why it happens.
So I think we've talked so far about like what you expect from a growth perspective until the onset of puberty. Once puberty starts in a child, again, it's generally thought of as like, it's, estrogen for the girls, testosterone for the boys, that causes the growth to start to accelerate. So for girls, you go from 2 inches a year to maybe 3.5 if it's kind of, really an aggressive growth spurt. For the boys, they again have a little bit more of an aggressive growth spurt. You expect closer from between 3 to 4, sometimes unusually even higher than that as a growth spurt. And that is directly related to the production of the sex steroids or again, estrogen and testosterone. And why that's really relevant is for the group that are the late bloomers, which, as you said, is super common, particularly for boys. Your child may be doing, as I often say, their dutiful 2 inches a year, but their peers that have already gone into puberty are going to start growing 3 to 4 inches a year. And so do you see that even though there's nothing wrong with how your child is growing, if you look at the two groups together, you're going to see one group really taking off and one child that's kind of being left behind. And when you look at the kind of growth charts that all of us use, the growth charts look at averages. So the built into the growth chart is going into puberty on time. So for the late bloomers, they often look like they're falling off the growth chart at 11, 12, 13 years of age because everybody else is accelerating, and that's already built into the growth chart. But really, that's why it's relevant to calculate an annualized growth velocity every single time the child comes in and say, listen, your child is not in puberty yet. Your child's still growing 5.5 centimeters a year or 1 3/4 inches a year. Look, your child's growing in a completely normal way. They haven't started puberty yet. Give them some time. We got to be patient with their bodies. Once they go into puberty, that's going to be the opportunity for catch up. So again, delayed puberty for the most part is not pathological. There's no treatment really necessary if it's, in a relatively, typical time frame. Even though, again, as I mentioned, often those children are smaller than you would expect for their families, but they will have catch up. And there is for sure a genetic component to this, because often the parents have a similar history, or the aunt had a history like that, or the uncle, mom will be like, oh yeah, my brother was still growing when he was a junior in college. And I'll say, your brother was for sure a late bloomer, and whatever those genes were, they've now passed on to your child.
So looking at the growth chart for height, we can safely say that the constitutional delayed growth population, that whether it's 20% of the population, those who grow late through college, they are related to the late bloomers for puberty. They're almost
that's okay. The same diagnosis. So constitutional delay of growth, pubertal delay, or late bloomers, I think is kind of the more like colloquial term. That's the same thing.
Okay. Well, these are good connections to make, because we will look at one separately. And talking about puberty could happen in the pediatric office, but especially if you're new to your doctor, it is just skipped over. We don't, we want our patients to like us. If they're not comfortable with us, we're not talking about, the size of your child's testicles or where there's hair. So it is important to bring up with your pediatrician. You can do it outside of the office with a phone call if it doesn't feel right with, a boy-girl type of relationship, if they don't know the doctor. But after a while, at every visit, and I'm sure you're going to love hearing this, every visit, your child needs to be examined full head to toe, which means private areas. I mean, that I say that because pediatricians skip it way too often. Correct me if I'm wrong. I don't know if you even hear about this, but
I don't know if I necessarily hear about it, but I do see a lot of exams when referrals are made that are very clear that someone's looked. But looking, again, as I mentioned, if you're really doing a specific exam looking for pathology is not enough. You have to invade the child's privacy. Again, as I said, you got to feel the breast tissue. You got to feel the testicles to assess the size of the testicles. Because again, just visually looking, you're going to miss things. Also, I think a lot of people misinterpret hair in the context of puberty. And just to mention that hair growth, acne, body odor, especially early on in puberty for both boys and girls, is coming from a different source than where we could traditionally think of kind of, the hormones, the puberty, the quote unquote puberty hormones. So, we think about estrogen coming from the ovaries and testosterone coming from the testicles. Well, early hair growth, acne, body odor actually comes from a completely different endocrine system that is in your adrenal glands. So the adrenal glands are these little glands that sit on top of your kidneys that produce all sorts of super important hormones. But early on in puberty, they produce kind of weak forms of testosterone that cause hair growth and all those other things that I mentioned. And then as puberty goes on, the ovaries end up making so much testosterone. The testicles obviously make tons and tons of testosterone that system kind of gets overwhelmed a little bit. But the bottom line is, I often see referrals for puberty, and they'll talk about just hair growth. And although hair is important, it's actually not the pubertal sign I'm looking for. So for pubertal signs for children, for girls, it's breast development, and for boys, it's testicular enlargement. And the hair development is a completely different hormone system that controls that, and a completely different set of issues if it's happening too early.
And so important, because that's what parents see or come in with a concern for. Definitely worth talking to your pediatrician, because it can, if it's significant, it can signify a tumor or abnormal growth. But often it's quite normal. When I say often, almost 99% of the time when a patient comes in, it's normal. And I'm glad you spoke about children being overweight. I don't know if you see that being linked with more adrenal hormone, because you were saying it's the leptin. I do see people who are a little bit less active or have more weight, fat cells, that they and I haven't done a study, so I don't know. They do tend to come in with some concerns about early puberty, such as body odor. Is that just is there a correlation, or is that just a happen chance?
No, for sure. For sure. So we call that when prior to the age of 8, if someone is starting with those types of signs, so hair growth, body odor, acne, for both boys and girls, but much more commonly seen in girls, we call that premature adrenarche. So again, that means the adrenal glands have prematurely or early, too early, turned themselves on. And there is for sure a connection between weight and premature adrenarche. There are also other connections. So there are, if the child has a history of being small for gestational age, so if the baby was, at birth, the baby was small, or the baby was very premature, or if the child has any kind of underlying neurological issue, even children that are on the autism spectrum. So those are all risk factors, but weight is one on the list as a risk factor for the development of premature adrenarche. But so it's, even though it's correlative, the question is, wow, well, if this child didn't have necessarily an issue with weight, would the premature adrenarche have happened? And that is a question that I don't think we legitimately can answer. That if you are at risk for this happening, can you somehow do something to control it? That I don't know if we have the answer to, but certainly if there are concerns like that for families, we talk extensively about, all the things that I think people really, staying away from things that are, concentrated sugars. Like, I always say, don't eat your calories. Don't drink your calories. Eat them.
Absolutely.
If you're gonna try to provide fruit to your child, great. Have them eat the fruit. Don't drink the fruit. Particularly this year, where kids have been at home and online, and difficult to find opportunities to be physically active, kind of depending on what your life situation is really to try to maintain some type of physical activity. But your observation in your patients has for sure been shown in multiple studies that weight does seem to be a risk factor for the onset of adrenal.
And you beat me to my next question, because I did want to ask, what can parents do? What can you do if you have a 3-year-old and you're already worried about it? It sounds like just eat healthy foods. And you were mentioning before the show how people need to be comfortable visiting the fresh produce. That's paramount.
Yeah, I think one of the things that I think you had asked me before, and I ask this all the time, is what are my feelings about, hormones that are in the milk, or should everything be organic? And the reality is that there really isn't any definitive data for me to advise every patient that comes through to, only shop in the organic section of your grocery store. I think more relevant is eat fresh fruits and vegetables, try to avoid processed foods. I tell people this all the time, even though I realize that, this is a limitation for many families, and, we need to be mindful about how difficult doing this is. But, eating in your home is, even if you're eating the same food product, is going to be so much healthier than if you're eating outside of your home. And again, believe me, I live in a dual working household, so I know how difficult that is to make that happen all the time. So I think, we have to be mindful about that. It's hard for that to happen. And there are definitely communities, even here in Orange County, where there isn't a local grocery store, and getting access to fresh food is difficult. So those all things being true, I'm much more of an advocate of just, eating cleanly and being as physically active as you can be, rather than necessarily ascribing to a particular diet. And I only say that because there's just no data. If you are able to afford organic, food and milk, and you are a true believer that it has an impact on your health, please, go for it. If you can do it, great. But not everybody can. Not everybody can afford $7 for a carton of milk twice a week. So I think we kind of have to be mindful about that. I will say one little comment. There are a number of sources of estrogen that are commonly found that I think a lot of people ask me about.
Good. I was going to move to that. Before you go to that, it's a hot topic. I assume you also say that there just isn't clear research about VOCs, formaldehyde, those types of environmental factors. And I really love that you're speaking to that. I think we're still doing lots of research, but there has been lots of research. So I think the fear factor about, what furniture to buy, and I think if something clearly smells bad, for years, there's something wrong. But I'm glad you spoke to that, because we all kind of live in fear that we're exposing our children, but to something we shouldn't be.
The reality is that a lot of the things that have been implicated, and I think that there's legitimate concerns, right? Plastic, these types of things. It's just, they're ubiquitous. They're everywhere, right? So it's very difficult to avoid those things. And that's actually why it's really hard to do studies on these things, because how do you eliminate,
Totally.
an agent? There is some data coming from the Central Valley that there may be some pesticides that can be true endocrine disruptors, as they say, and can cause potentially an earlier onset of puberty. That girls in the Central Valley are being studied because there appears to be a trend of earlier onset. So there are colleagues of mine that are looking into that. So, time will tell if that translates into something that the rest of, those of us who don't live there, but frankly eat food that comes from that area, that something that we need to worry about, one way or the other. But at this point, the jury's out.
Okay,
What
and
I was
what you were gonna say was about estrogens and
so like things that have been implicated as kind of estrogen promoting agents. I'll list them. Lavender is one. Tea tree oil is another. Soy is another. And there are some case reports of boys that had breast development, so what we call gynecomastia, that seem to have an exposure to tea tree oil or lavender. And it appeared that, again, these are case reports, that when they removed those agents, that the gynecomastia improved. When they've tried to kind of look at the precocious puberty population, it doesn't seem to be correlative one way or the other. So, I ask about exposures, of course, all the time, because I was going to say the last thing to mention is a lot of hormone containing substances for themselves. So I have had patients over the years whose dads use a testosterone cream, and always important to realize that anything you put topically can transfer from one person to another. So most people have been instructed, if you're going to use a testosterone cream, you got to put it like on your back or somewhere where your small child isn't going to get a hold of. I've had grandmas use like an estrogen cream and then take care of the child, and then that induced breast development. So we ask about every child that comes with early onset of puberty. That is on the list of things that we ask about, is we ask about exposures. That's relatively rare. But people ask about these types of things like lavender and tea tree oil, and I say, again, if you're looking at like cleansing products, those types of things are in so many things. So you just kind of want to be mindful about that. I mean, again, if your child does have early onset, you may want to eliminate those items. But could I say that that is what caused the precocious puberty? I don't think that that's necessarily fair to say. Soy gets a bad rap because it does have estrogen promoting qualities. But actually, when soy has been studied in women, for example, in terms of their rates of breast cancer, actually women that have higher soy intake have lower rates of breast cancer. And that may have to do with like how they're living their life, right? Rather than necessarily the soy being protective.
Correct. Yeah, because they're eating healthy. Yes, my sister, being a breast cancer survivor, avoided soy for a very long time, and then working in a clinic where we looked at health foods, there's just too much to lose by not eating it.
Yeah.
So thank you for speaking to it. I know it's so inconclusive, but you actually answered a lot of great questions. Really good, high yield information. Okay, well, why don't we move to the next topic, which shouldn't take long. There's been a couple questions coming in about growth hormone and when we use it, why to use it, and what are the pros and cons. And one question that came in is 16 too late? And I guess you'll explain probably what it depends on.
Sure. So it's such a broad topic, but I'll try to kind of like pack it in.
Yeah, I guess maybe what you see the most as far as questions coming at you, maybe even your personal life, being an endocrinologist with friends in the community. I'm sure they ask you.
Yeah. So, I'll try to condense things as quickly as possible. So, when I look at children who are referred to us for, quote unquote, short stature, and I say it in quotes because short stature is relative. Mm-hmm. And it's actually like, I'm not saying it in a pejorative way, like it's literally relative, right? So if like, the average height for your family is 6 feet tall and your kid is at the 20th percentile, they're short.
It's one of the most awkward moments when the parents are complaining about how short they are. I'm looking at them. I'm like, it's your child, right?
Right. Right. That's what I'm saying. So if your child, if you have a very high height potential for your family, even if the child's still on the curve, your child may be short. But if your height potential is like at the 10th percentile, and your child is at the 5th percentile, like that's normal, right? That is normal human variation. And so it's short stature. That's why I say it in quotes, because I think it's, you really have to compare a child to a family. So I'll just say that, I think about children in buckets when they come to kind of see me. And I always tell families this: my first job is, obviously your pediatrician has been worried about your growth, and that's why they're sending you to see me. My first job is to figure out, as the best of my ability, what's wrong. And then the second question is to decide collectively what we need to do about it, right? So the first question, and again, often that's why I really want to go back to the growth chart. The first question is often answered by the growth chart. So if a child is following their curve, wherever they are in the curve, first percentile, 10th percentile, 50, doesn't matter. Following the curve, the likelihood that there is something pathological about what's happening with that child's growth is low. Not to say it's never, but it's low. So frequently, the reason people are being referred to us is because they're not following a growth curve. They're quote unquote falling off the growth chart. So they're not doing their 2 inches a year. They're doing it an inch, 3/4 of an inch. They're falling off the growth chart. So that's why I say I think about kids in buckets. So the first bucket, which is actually a rare child to come to see us, has a true hormonal deficiency. So they have a thyroid hormone deficiency, they have a growth hormone deficiency. If you're referred to our division, sometimes it can seem kind of frustrating because we're asking the pediatricians and the parents to get labs and an evaluation before you come to see us, because not everything is hormonally related, right? So your kid could have a kidney problem, or your child could have celiac disease, and that's not an endocrine problem, and I need to direct you to somewhere else. So there's a laundry list of labs that we ask you to do. So again, in a minority of circumstances, there's a true hormonal deficiency that's causing an impairment in the child's growth, and that's a relatively easy thing to diagnose with a relatively easy answer, which is you just need to replace what the child is missing. Then there's like buckets of kids that have a syndrome of some sort. So some type of underlying genetic problem that is impairing the child to grow in a typical way. And we kind of keep an eye out on for that. There may be certain other features in terms of what the child looks like that can clue us into that. Then another bucket are kids, as you mentioned, that have delayed puberty, which, as I mentioned, isn't necessarily pathological and doesn't necessarily need treatment. So again, as I mentioned, frequently those kids are lower on the growth chart than you would expect for their families. Usually they're growing in a completely normal pattern. They're doing their 2 inches a year, but at the onset of puberty, they will look like they're falling off the growth chart because everybody else is accelerating. But I understand the anxieties of families. I have 2 little boys, and I get it. That, particularly at around 11, 12, 13 years of age, everyone else is having a big growth spurt. Your child looks like they're falling behind if they're involved in sports. Believe me, I get it. There's issues there. But there's that cohort. And then there's another cohort that were small when they were first born, as we say, small for gestational age. And a group of those kids will not catch up to where they're supposed to be for their family. And so that's another group that we look out for. And I may be missing a couple other groups, but the largest group is the group where there's really no pathology, there's no great explanation for why that child isn't growing well, but the child is not growing well. And when we do the evaluation, we don't find anything too exciting. But when I try to do some prediction in terms of where that child's going to be at the end of the day, that child looks like they're going to fall short from where they're supposed to be from their family. And what do we consider short? This is where it's relative. We consider short a child that is projected to be less than 2 standard deviations from the average height for their family. And so, again, if your child's is the normal height for your family, let's say for a boy is 5'9", that's the average height for a man in North America. So that means the average height for your family is someone to hit the 50th percentile. That doesn't mean every kid's going to hit the 50th percentile, but within reason, most children within the context of the family will be somewhere between the 25th and 75th percentile. In a minority of circumstances, they'll be somewhere between the 3rd and 25th, right? It becomes like statistic. But if your child's going to be less than the 3rd percentile, so 2 standard deviations away from the average height for your family, then someone like me starts saying, I need to figure it out. If I can't figure it out, you're just kind of in this grab bag of, I'm not sure exactly the reason why, but your child is going to be pathologically small for your family. And the reason we do that exercise is the second question, which is the treatment question. So the criteria for treatment is Any one of those other things that I mentioned, if you have a true hormonal deficiency, if you have an underlying genetic problem that has been identified as responsive to growth hormone, if your child was small for gestational age and did not catch up, or if your child's height is projected to be, again, at the -2 standard deviations away from whatever the average is for the family. And that's why calculating family averages are really relevant. And I know parents hate this when we do it, but we actually measure parents when they come to clinic. And it's not because we're trying to embarrass anybody or whatnot, but it's really because that's how I define pathology. So if you tell me you're a particular height and you are not, I may be going down a rabbit hole in terms of an evaluation for your child that was maybe necessary, or the opposite, or maybe I'll be dismissive about it, but I shouldn't have been.
This is just such a great conversation for how often this comes up and getting just right to the details. And I'm glad you clarified something that I was going to ask you about gestational age. I'm typing and writing. The small for gestational age, oftentimes they will catch up just fine, right?
Literally 90% of the time, they will, by age 2, they will have caught up. And it is only the outliers, again, that after age 2 or 3 years, if they have not caught up, they likely won't catch up. And the small for gestational age, as I mentioned, is also a risk factor for early onset of puberty. So those are kids that I've watched very, very carefully, even outside of the context of growth hormone, that if they haven't caught up, they are at risk for starting puberty early. And can you see that it can be like a perfect storm of events where that child ends up being very, very small for the family because they were already small, they didn't catch up, they go into early puberty, and then they fuse super early. So that's definitely a group that I watch very carefully, but you are right. The mass majority of those children by 2 to 3 years of age have completely caught up, and there's no issues with their growth.
And when Dr. Forghani is saying fuse, she's talking about the ends of the bones, the growth plate fusing. And then of interest to me, when you say that these people who come to you with 2 standard deviations, clearly an outlier from their family, do they need to meet the same criteria in bone age studies, because we do x-rays to see what their growth is, and do you have to find a growth hormone deficiency to treat?
So the first part of your question is, we have these prediction models for growth that really only, so first of all, they're not real predictions, right? They're like, our best guess. And they really become very, very subjective when the children are young. So I usually don't get bone ages in very young children. It's very difficult to assess that.
What's very young?
Less than 5 or 6.
Less than 5, okay.
Less than 5 or 6. So a bone age basically is an x-ray of your child's hand. There is a relatively well-validated book that we look at that compares not the size of the bones, we don't care about that, but the relationship with the bones. And there's characteristic, a 7-year-old boy's bones look like this, a 10-year-old boy's bones look like this. And why it's relevant is that it gives you an idea of how much time that child has left to grow. So if you have a 10-year-old boy who has a bone age of 8, does that mean there's something terribly wrong? Not necessarily. It just means that their body feels younger than their chronologic age, which probably means they're going to go into puberty a little bit later than everybody else. And on good news for their growth is they have 2 more years to grow in comparison to everybody else. This is how the late bloomers catch up. This is how that works. So that projection algorithm, the prediction that you said, the 2 standard deviations, the bone age is a part of that prediction. So you say this child's height is this and their bone age is this. And then there are these prediction models that we have to say, where is that child going to be at the end of the day? And again, it is not a perfect science. We're not going to say, oh, that kid's going to hit that target exactly. But within an inch or 2, we're relatively close. And then again, from my perspective, I see who's an outlier and who is not an outlier. Who's, if that example that I gave, if 5'9.5" is the average height for your family and your child is going to end up being 5'7.5", that's not an outlier, right? But if that 5'9.5" family has a son that I'm projecting to be 5'4", Again, I need to do some investigation to figure out why that is happening.
Mm-hmm.
And then B, if I identify something, great, we can kind of move forward with that. If you do not, then the conversation with the family is, okay, do you want to pursue treatment? The question you had is, do you have to have a true hormonal deficiency to get on growth hormone? And the answer is more complicated than just yes or no. So if you have a true hormonal deficiency, and from my perspective, a true hormonal deficiency is growth hormone comes from your brain. So a true hormonal deficiency is your hormone levels are low, and I can find something pathological in your brain. And it doesn't have to be something scary. It could just mean that your pituitary gland is small, which is where growth hormone comes from, right? So
and how young does this come up? Because someone wrote earlier in this show about giving growth hormone to a 2 to 4 year old. Do parents regret not doing it? Which is surprising. I guess those would be exactly your scenario where there is a pituitary tumor or a reason that it's not grown. They're not growing.
That's right. For a child to be offered growth hormone that early or even recommended, there is usually a true hormonal deficiency. I mean, when we're talking about like a pituitary deficiency, I mean, sometimes those kids are identified right at birth. And if you don't give those kids growth hormone, again, in that situation, you're not really, growth is just a side effect of the treatment. You're physiologically replacing them. So, children with true growth hormone deficiency can have low blood sugars. I mean, there's a laundry list of issues that can be related to that. And so when you're using growth hormone like that, you're using it as a replacement. But timing is relevant. If you're using it, again, as a replacement, you want to start that early, right? You don't want to be, growth hormone has all sorts of physiologic effects other than just growth. There's muscle development, there's, bone health, there's all sorts of other things that growth hormone does. So you want to replace that early. But when you're talking about just augmenting growth with growth hormone, there's also a window. There's no data to say if you're on treatment for 15 years, it makes that much of a, versus 5 years. The longest studies we have are people being on treatment for somewhere between 4 to 5 years. So again, this is in the context of somebody who makes growth hormone. Maybe their production is a little bit low, but doesn't have a true growth hormone deficiency in the sense that, isn't growing at all, fell off the growth chart, has, low, has a pituitary problem. I'm talking about kids that are small. Again, maybe you find slightly low levels. You may even call it like a partial or a mild growth hormone deficiency. When you use growth hormone in that context, the amount of growth that you're going to get is not as robust as someone who has a true deficiency. Again, it's like, you're filling the bucket full of growth hormone, but if the bucket's already like half full and you're just adding a little bit more, you're not going to get that much growth. The best studies for efficacy of growth hormone, again, this is in the non-growth hormone deficient group, is about 1 centimeter more than the child would have grown per year of treatment. Remember, growth hormone is an injection nightly basis. And so over a 1 year period of time, you would gain 1 inch above whatever the child would have grown anyways. 4 to 5 years of therapy, you get about 2 inches. You had asked me about what about a 16-year-old? The question is are the growth plates open in a 16-year-old? Most 16-year-old boys are either totally closed or very close to being closed. And so growth hormone isn't something that you do for like 6 months. There's no efficacy. Bones grow slowly. So if you're going to put your child on treatment, you need time. Now, again, that's why I say, like, should you start when they're 2? Most people are not going to offer growth hormone unless there's something really pathological there. So there's no evidence to say you need to start at 6 or 7, but you need somewhere between 3 to 5 years for it to have any real effect on your child's growth.
So there are families that qualify and start at 2, 3, 4, 5. It's not something you do right before puberty.
Yeah, it's unusual to start growth hormone that early, but sure, there are children that start that early.
And I had a particular patient who ended up with some very severe scoliosis, and somebody asked, do people regret not doing it? And I've had patients regret doing it because sometimes you don't have to, right? And then there was scoliosis, which you can't say for sure it was the growth hormone, but I guess there is a correlation.
Oh, for sure. So the three main side effects of growth hormone are one, something we call pseudotumor cerebri, which is extra pressure in the brain. It's reversible. So if you take somebody off of treatment, the pressure goes away. The sign of it is like a really bad headache, right? So it's like a headache that doesn't go away. So that's one. Scoliosis is two. It is not necessarily thought that growth hormone causes scoliosis, but actually can perpetuate it or make it worse. So it's actually a contraindication to treatment. If you have scoliosis, either during treatment or before treatment, depending on the degree of scoliosis, but if it's significant scoliosis, you should not be using growth hormone. And number three is, again, another medical condition that we call a skiffy, that in the femur, the big bone in the leg, not at the ball and socket, but actually at the place where the bone grows, the epiphysis, the place where that can slip out. And if it occurs, that does need to be surgically pinned back together. So those are the three kind of big side effects of growth hormone. They're rare. Reported is about 1 out of 1,000. But I would say the scoliosis that you mentioned is probably the one that I see most commonly. And probably that's related to the fact that we take care of children that have all sorts of other underlying issues, genetic problems that put them at a higher risk for scoliosis. But yes, growth hormone is not benign. I say that to families every time I start treatment. If I thought it was unsafe, I would never prescribe it to anybody. So I do think that growth hormone can be very safe, but that is why there is criteria for use. And I think that sometimes that can be disappointing, that families come thinking that they're literally coming to get the growth hormone. Mm-hmm. And we tell them, we have a legitimate medical practice, right? We just don't do cosmesis, right? I know, in Newport, I think, sometimes there's a misinterpretation of like, well, how we practice medicine, right? We're not about cosmetics. We are about treatment of medical problems, and we have followed national and international criteria for use of all medications, because I don't want to cause harm to your beautiful child that's sitting in front of me. That's my first rule: do no harm.
Yeah, it's so important. And we don't even know what happens to this population in 50 years. So there's always that unknown when you're doing medicine to a growing body. Things look pretty good so far. But I know that when I talk to IVF doctors, if someone can do it naturally, do it naturally, So you offered a little bonus talk. Is there anything else you want to speak about regarding growth hormone? I think we go on and on and on, but I can't tell you that how valuable you've hit all of the key topics, and I can tell you must be getting the same questions that we get in our office. So if we are okay, I'd like to move to type 1 diabetes, because it's almost like a cliffhanger. You said, and I could talk about type 1 diabetes in light of the pandemic, and I got to meet with you away after my son was diagnosed last year. And for me, I just try to not read the news about whether it's related or not, because what can we do? But I'm so curious what you wanted to say about it.
Sure, we can move to type 1. It's about 50% of our practice is diabetes. There has, of course, been a lot of interest with either, risks for patients with type 1, or risks with, kind of increased onset of diabetes and type 1. And I would say the overall synopsis, nationally as well as locally, is that the jury is still out if there's any increased risk or correlation, and likely, at least at this moment in time, there does not seem to have been an increase in the rates of type 1. But the asterisk to that is that it may be early. So just to kind of review, and many of your patients or families may already know this, that type 1 diabetes, there's many, many different types of diabetes, but the type of diabetes that affects children most of the time is called type 1 diabetes. It's an autoimmune disorder, which means that the body's immune system that's supposed to be fighting against infections and viruses and bacteria and all that is doing that, but at some unknown moment in time made a very terrible decision, and the immune system, due to some unknown trigger, started attacking the cells of the body that make insulin. And insulin is essential for life, and insulin is necessary for the cells of the body to use sugar. And frequently people know this because blood sugars go up if you do not have insulin in your body. The kind of most common signs of type 1 diabetes is going to the bathroom a lot, feeling thirsty a lot, and losing weight. Those are the most common things. Almost 100% of the time, parents will report some history of that, whether it's a week, 2 weeks, sometimes it's months, but some history of that. So the child's thirstier than usual, the child's going to the bathroom a lot more frequently. In a potty trained child, it's a child who starts wetting the bed all of a sudden for no good reason, or a teen that's you start hearing in the middle of the night getting up and going to the bathroom. And then again, weight loss is almost universally seen as well. If especially younger children frequently come later to medical attention, because some of these signs, it's hard to tell if your child's already in a diaper, like how much they're really peeing. And so sometimes some of the later signs is a child that's vomiting uncontrollably, or having difficulty breathing, kind of deep breathing, that often is misinterpreted as like pneumonia or some type of respiratory issue, and a parent will bring the child to medical attention, and then they'll be identified as having diabetes. So because of this unknownness of the trigger, that is the trigger that causes type 1 diabetes, most people believe that there is some type of a viral trigger that is the impetus for the cells to start this process of being destroyed. But I say it's unknown moment in time because for most patients that get diagnosed at time 0, that process likely started 6 months, 9 months, it could even have been years prior to the actual onset. So it becomes very difficult to identify what is it that that started this process. And so if you can imagine, a lot of people have been interested if COVID could be a trigger, because there's so many things about that virus that are unusual and so many things about it that we still don't know so much about. And so this has been actively studied. And most of us have not seen a notable increase in diagnosis of type 1 diabetes this year. But again, we're literally tabulating data at CHOC. We are a part of multiple hospitals in the country, what we call TrialNet, which is a consortium of hospitals that do research for type 1 diabetes, or the type 1, or what we call T1D exchange. Again, another kind of, multiple hospitals around the country, just because even though type 1 diabetes is very common, just to mention, 1 out of every 300 kids in Orange County will develop type 1 diabetes. It's extremely common. But still, it's not common enough for like only one hospital to be doing research by themselves. So we collaborate all over the country. And again, thus far, no one really thinks that type 1 is on the rise. But as I mentioned, the trigger for type 1 could be years prior to the actual diagnosis of type 1. So we do not know the answer to that question.
I have some people writing in questions and lots of questions, but we have run out of time. So maybe we'll do a show on diabetes, because some people have been asking how to prevent type 2 for children with, belly fat. So why don't we?
I'm just going to say one last thing, because I would be bereft if I missed this point. Even though there has not been an increase in type 1 per se, there has been a exponential increase in the of rates of type 2 in children nationally. That has been, we are seeing it in an epidemic-like fashion here at CHOC, and that has been seen all over the country. The American Diabetes Association meeting was about a month ago. Children's National in DC was showing exponential increase in numbers. So if I can leave your audience with one thought, is that, let the kids not be the victims of this epidemic, and that their weight and exercise and their health is being affected in ways that we don't even understand. And that keeping our kids active, being mindful about how you're feeding them, being mindful about what they're eating when they're not in your homes is super, super relevant. And we are worried about how we are going to be able to take care of this patient population that is aging and is so young.
I have seen it in my office. It's shocking to get blood glucose thinner, what would seem to be healthy, but they're not eating well. So thank you. This is just so useful. I'll probably listen to it twice after we finish. I always do. And there's plenty of pediatricians and doctors who love listening. And I think this one will be a great one. So for people to listen to when they're cleaning the kitchen. Thank you so much for your time. I might be begging you to do a type 1 and type 2 talk when you have time. It might take a whole nother year, but I'll wait. Your time is so valuable. I appreciate you being here. And anything else you want to add?
No, it's my pleasure to be here. Thank you for all you do for the community, and I look forward to talking again.
Thanks. And there's quite a few thank yous here too in the comments. So everyone's sending their gratitude. Have a great day.